Hey future nurses, welcome back to Scrub and Spoon. How are you all doing? Thank you for your support as always. So today we will be reviewing prioritization questions, right guys? This is very important. NCLEX trip students on this type of question. NCLEX don't spare you because they know it is one of the challenging topic or challenging. It's one of those challenging questions for nursing students. So we will be talking about prioritization. We're gonna have like 4 patients. Which one do you have to assess first? Who is of most priority? So guys, you have to stay tuned because this video might be long, right? And before we go into it, also please do not forget to subscribe, to like, to watch till the end, and put in the comment section your best part of this video. Now guys, let's go into it. Before I read the first question, let me prep your mind. When we are talking about prioritization questions, let me give you tips. Think about when you are faced with prioritization questions. I also made video on 5 NCLEX 5 test taking strategies that will help you to pass your NCLEX. Go review it on my channel. Now, when we are talking about prioritization, you want to assess your, let's say you have 4 patients, you want to assess that, okay, which of these patients needs immediate intervention? Because if I do not intervene, it might lead to death for them, or their condition might get worse. Who needs immediate saving? That's when you're talking about prioritization. Also remember your ABC, airway, breathing, and circulation. So when you see questions, apply ABC. Okay, is there airway in this question? Because airway takes priority. When the airway is blocked, the patient is dead. So never place anything above airway, right? So use your ABC. Also, if ABC is not applied in that question, use your Maslow hierarchy of needs. That is your patient's physiological needs first. Physiological needs like food, water, rest, elimination. That will guide you, right? To say, okay, what do I have to do first? Who do I need to attend first? If that does not apply, then think about your ADPI, your assessment, your diagnosis, your planning, your intervention, and your evaluation. Apply that. Okay, do I assess this patient first? And after assessing, what else do I do? Do I carry out the plan and evaluate the plan I carried out? And also during prioritization, think about stable and unstable. You know, when you are supposed to prioritize, you have to prioritize unstable patient before stable, because it is unstable patient that needs immediate intervention, not the stable patients, right? Now let's go into the first question. Now this is heart failure patients. Which clients should the nurse assess first? A client with bilateral leg edema and crackles in the lungs. B, a client with 3+ pitting edema asking for a diuretic. C, a client newly diagnosed with heart failure asking about a low sodium diet. And D, a client with heart failure who gained 3 pounds in 3 days. Guys, what is the right answer? Remember, airway, breathing, and circulation. And guys, the right answer is A client with bilateral leg edema and crackles in the lungs. Let me explain this to you. They have heart failure and they have both legs bilateral leg edema, as both legs have accumulated fluids. And look, crackles in the lungs. What does that tell you? Pulmonary edema, pulmonary congestion. That means they have accumulated fluid so much in the lungs. And guess what that will do if not intervene? Too much accumulation of fluids in the lung will affect their breathing, airway, breathing, and circulation. And that is why this patient is your most priority, because you do not want anything to affect airway, breathing, and circulation. It will be difficult for them to breathe. They start having shortness of breath. They start having low oxygen saturation. So that is why that is your priority, right? Now let's go through the wrong choices. B, a client with 3+ pitting edema asking for diuretics. Okay, yes, they have pitting edema, because edema signifies that or indicates that the body is accumulating fluids. But there is already a treatment ongoing or management. They have diuretics. And edema will not, it's not life-threatening. Right now, it's not life-threatening. It's not going to cause them to stop breathing. Like I said, who needs immediate saving? Who needs immediate intervention? Edema in the leg will not stop them from breathing. So that's why that's wrong. Now let's go. A client with newly diagnosed heart failure asking about a low sodium education. So low sodium diet. Guys, this is patients needing low sodium diet education. Education can wait. Because, okay, think about it. You want to start educating them while there's a patient that is finding it hard to breathe because there's too much congestion and fluids in their lungs. You want to leave that kind of patient and start talking and start educating a patient about low sodium diet. No, you don't want to do that, right? Not at all. And D, a client with heart failure who gained 3 lb in 3 days. Like I just said, they gain 3 pounds body weight. That will not kill them fast, like right now. It is actually concerning, because if they are gaining weight, it shows that the heart failure is getting worse and they are accumulating so much fluids in the body. But it's not immediate life-threatening. It's not immediately life-threatening. Priority, who needs to be saved immediately? That's why this answer is wrong. This D also needs to be reported to the doctor or the provider, right? But it's not life-threatening. That can wait, right? We are good. Now let's move on. Now, which client on the oncology unit should the nurse assess first? A client receiving chemo who has a temperature of 38.9. B, a client who is bald and crying. C, a client with nausea after chemotherapy. D, a client asking when their lab results will be ready. Guys, I know the answer is obvious. The right answer is a client receiving chemo who has a temperature of 38.9. What is that telling you? Now, when they have cancer, they are already immunocompromised, right? And they have this temperature signifying infection, right? And you know, when they have cancer and they're going through chemotherapy, they may likely experience neutropenia, that is reduction or deficiency in the white blood cell called neutrophil. And we all know what neutrophil does in the body. Neutrophil, white blood cells, does in the body. They help to fight infection. But this patient, and you know, chemo can kill all good and bad cells in the body. This is a sign of infection, and it needs to be addressed immediately compared to the list we have. And if this infection is not treated, it might lead to sepsis, risk of sepsis, right? And that's why it's your priority. Now look at the wrong choices. A client who is bald and crying. Now this is like an emotional distress, because you know, they have cancer and cutting off their hair can change the way they see themselves, can change body image. So they are going through emotional distress. It is important, but it's not life-threatening, right? And C, a client with nausea after chemotherapy. Usually nausea is expected after chemo and it's always managed. Usually when I worked on oncology floor, there's always medication for nausea, PRN, in case they need it, right? So that's not life-threatening. It's managed. Guys, we are good. Now, this prioritization is between patients that had post-op abdominal surgery. Let's go. Who should the nurse assess first after shift change, right? A client who has not voided 6-hour post-op. B, a client whose dressing is saturated with bright red blood. C, a client who reports 3/10 pain at the incision site. And D, a client asking when they can eat again. Now, what is your answer? And the right answer, guys, is B, a client whose dressing is saturated with bright red blood. I know you are contemplating between A and B, because C and D are obviously eliminated. They are obviously wrong. And like I said, go watch that video I made about 5 NCLEX test taking strategies. Something like this is in it. Process of elimination. You've already eliminated the obvious wrong choices. Now you are left with 2. And I know you are considering, like I said, A or B. And the right answer, like I said, is B. Why? Let me explain it to you. Now look. A client whose dressing is saturated with, the key right there is bright red blood. That is signifying or suggesting active bleeding. They are actively bleeding. And if you watched some of my video, I told you guys that after surgery, there are 3 things you should be concerned with: DVT, hemorrhage, and infection. Right now, this patient is hemorrhaging. They are actively bleeding because the bright red blood suggests that the bleeding is ongoing. If it were to be bleeding from when they had surgery, it will be dry and dark. But bright red bleeding suggests active bleeding. That is why they are your priority, because they're actively bleeding. And look, they've had surgery a long time ago, because this is after a shift change. Like some shifts, someone has you resume a new shift, your shift after someone else ended. You resume your shift as the nurse. You assess this patient first, because now that that after surgery they are bleeding, it can lead to hypovolemic shock because they are losing so much blood after surgery. It's life-threatening. So you need to assess them immediately. If the blood were to be dark and dry, no need. But bright shows that they're actively bleeding. And that is why that is the right answer. And what you have to do also, you have to also check their vitals to see, you know, vital signs tell us the state of the body. It will tell you what their blood pressure is, what their pulse is. You'll be able to know because you have to report this to the provider, the doctor, the surgeons, that okay, this is what's going on. The patient just had surgery and this is what's going on. Because they'll ask you, did you check the vitals? So you have to have something to tell them, right? That's for that. Now let's go to the A that a lot of you guys might have picked. A client who has not voided 6-hour post-op. Now let me tell you something. Depending on your facility, some facilities allow between 6 to 8 hours if a patient didn't void after surgery before they start any intervention, right? And because also during surgery they took anesthesia, and that also can suppress the urge to pee. It can also reduce reflexes, your urge to pee for the bladder, right? And what the nurses can do, they can use bladder scan to see if the bladder is actually full or what's going on. You can also palpate the abdomen a little bit or encourage them to pee, right? And if it's a surgery that was not so serious, if they can move, when they start ambulating, that can also bring on urine for them to be able to pee. But it's not immediately life-threatening. Like I said, bleeding, hemorrhaging after surgery can lead to hypovolemic shock. You do not want your patient to go into shock, and that's why you have to check the vital signs, because like I've always said, if the blood pressure is low and the heart rate is high, signs of shock. So the surgeon will ask you, did you check the vitals? What is going on? Okay? And C, a client who report 3/10 pain at the incision site. They just had surgery, pain is expected, and 3/10 is not bad. It's not life-threatening because we are dealing with prioritization. And D, a client asking when they can eat again. I know before surgery they might put you on MPO. This is of the least important. This is not life-threatening, and that's why our right answer B is right. Now let's go into the next one. Which patient should the nurse see first? Type 2 diabetic with a blood glucose of 58 and confusion. Type 1 diabetic needing insulin education. Diabetic with dry skin on feet. And diabetic asking about diet options. What is your answer? Guys, and the right answer is A. Type 2 diabetic with a blood glucose of 58 and confusion, 58 mg and confusion. You know why? First, think about what is the normal range for your what is the normal rate for the blood glucose? 70 to 110 mg DL, right? So it's indicating that this patient is already hypoglycemic, right? And it needs to be attended to immediately, because look at the symptoms, signs and symptoms. The symptom says, and confusion. What is that telling you? It is already affecting the brain. The blood glucose is so low and getting severe that it's already affecting the brain. They are confused, right? And this needs to be attended to, addressed, intervened to immediately. And if you've seen my video, I've told you guys, hypoglycemia can kill your patient faster than hyperglycemia. So you do not want to leave them untreated or unattended to. It can lead to death, it can lead to coma. Okay? This is why that is your priority. I'm not saying hyperglycemia is not dangerous, but hypo kills faster. Because with hyperglycemia, they can easily give them insulin to drive the glucose into the cell, right? So they are both very important, but hypoglycemia kills faster than hyperglycemia. So you don't want to, and what you have to do is you have to give them fast and easy to digest carbohydrates if they are conscious, right? To quickly boost their glucose level, their sugar level, right? And if they are unconscious, you give them, if they have hypoglycemia, they are hypoglycemic and they are unconscious, then you give them glucagon. Okay, IV glucagon. Now let's go through the wrong choices. B, type 1 diabetic needing insulin education. This can wait. Education can wait. Remember, type 1 diabetic patient or type 1 diabetes is always insulin dependence. They take insulin for the rest of their life, right? While with type 2 diabetes, you can do lifestyle modifications before eventually assuming insulin therapy, right? So education can wait. C, diabetic with dry skin on food. Now, dry skin on food for patients with diabetes may be chronic complication of diabetes, right? And dry skin for them can lead to skin breakdown or infection. But it can wait because we're thinking about who needs saving first, who needs saving immediately. That can wait. And remember, with your patient that has diabetes, diabetic patient, make sure that their feet is in between their feet is dry. In between their toes is dry to avoid fungal infection. Okay. The last one, diabetic asking about diet options. Diet options and education can wait. They are not life-threatening, and that's why our answer, which is A, is right. Okay. Which patient should the nurse assess first? A 40-year-old with crushing chest pain and diaphoresis. B, a 70-year-old with chronic angina requesting nitroglycerin. C, a 60-year-old with GERD and chest discomfort after a meal. And D, a 25-year-old with anxiety and heart palpitations. And guys, the right answer is A, a 45-year-old with crushing chest pain and diaphoresis. Why? Crushing chest pain and diaphoresis is indicative or suggesting MI, myocardial infarction, heart attack, right? I know you might be contemplating between A and B, a 70-year-old with chronic angina requesting nitroglycerin. But let me explain this to you. Let me differentiate myocardial infarction versus angina. Now, angina is a sudden lack of oxygen to the heart muscle, and that will cause chest pain. And it is relieved with rest. There is stable and unstable angina. The stable angina is relieved with resting, and the signs and symptoms last for like 15 minutes. Now, MI, myocardial infarction. This is complete blockage of blood flow to the heart, which is life-threatening. It can lead to death, right? And I want you to remember the first aid treatment for MI is ONA, oxygen, nitroglycerin, aspirin, and morphine, right? It used to be MONA, but now it's been updated to ONA because ONA is the correct order of application, the way you apply everything, right? So this is why crushing chest pain and diaphoresis is suggesting MI. So the way I've explained MI versus angina, you can see that MI is more serious. Myocardial infarction is more serious than the angina they're experiencing, that the patient B is experiencing, right? And that's why the answer is right. Now, for B, the wrong choices. This patient is 70-year-old with chronic angina requesting nitroglycerin. This seems to be like a known chronic condition for this 70-year-old patient, because the patient is the one requesting nitroglycerin. But when you compare the two situation conditions, you know the first one is very serious. The B is also serious, but not as life-threatening. You also want to see stable versus unstable, because with angina, the signs and symptoms can disappear within 15 minutes. And when they rest, because sometimes the chest pain, which is angina, can come on because of strenuous activities. When they rest, they are relieved of the chest pain. But with MI, you have to intervene. It's not going to go by itself. You have to intervene. That's the difference, okay? Now, GERD pain is non-cardiac relating, right? So it's not related to the cardiac, it's related to the stomach, reflux. So it has nothing to do with that. So it's not life-threatening. And the last one says 25-year-old with anxiety and palpitations, right? Anxiety and palpitation may be uncomfortable, but they are not immediately life-threatening. As to somebody that has blockage of blood flow to the heart, that's more dangerous. Are we good? Okay. Now let's go. Which child should the nurse assess first? A 6-month-old with seizure and post-operative sleepiness. B, a 4-year-old with 39.5 degrees Celsius fever and sore throat. C, a 5-year-old with rash on leg and itching. And D, a 2-year-old with vomiting and diarrhea for 24 hours. And guys, the right answer is A, a 6-month-old. Look at the age, 6 months, with seizure and post-operative sleepiness. First off, seizure is a neurological emergency combined with post-operative sleepiness, that is excessive sleepiness or drowsiness that occur after seizure. This can lead to death or another seizure. if not intervened to, right? And remember, infants, they have immature brain, and post-ischemic sleepiness can progress to apnea when you stop breathing during sleep for a while and then kick up again. Apnea, aspiration, or another seizure. This is why that's the right answer. And remember, one of the concerns with during seizure is aspiration and airway constriction. Because like I said, A, B, C, when the airway is blocked, the patient is gone. The patient is done and gone. That is why that's the right answer. Now, let's go through the wrong ones. B, truly the child is 4-year-old and they have high temperature suggesting fever, and the sore throat may suggest strep or viral infection. But there is nothing indicative of respiratory distress. They are not using accessory muscle to breathe. They have sore throat and fever, but they are somewhat stable compared to the first patient, right? And the first patient is 6 months old. This is a 4-year-old, okay? So there are signs, there are symptoms they're experiencing, that this child is experiencing, is not of greater priority to somebody that may experience seizure for 6 months old, okay? Now C, a 5-year-old with rash on the leg and itching. Now they are 5-year-old, so rash on the leg is not life-threatening. So why would we leave somebody that may die from having several seizures, airway constriction? Why would we leave that person to go and attend to a child that have rash on their leg and is itchy? The parents can apply cream on the leg, right? So it's not of priority. And D, a 2-year-old with vomiting and diarrhea for 24 hours. I know this, when you see 24 hours, I know this might be tempting for you to pick as the right answer also. For a 2-year-old that is experiencing vomiting and diarrhea, this child is at risk of dehydration, which is very serious, right, for a 2-year-old. But in the question, it does not mention that the child is lethargic, unresponsive, or unable to drink. Even if they are vomiting, right, it might not be every time. So the child might still be able to drink something, put something in. And that is not life-threatening as much. See, you might be faced with a series of very serious conditions, but one will be serious than the other. One will be more life-threatening than the other. That is what we are facing now, because of everything, all these patients need intervention, but one needs more intervention than the other. And that is what prioritization is about. Who is likely to die as soon as possible, ASAP, if not attended to? Okay, so the child is somewhat stable more than the child that is 6 months and might likely die from seizure. And that's why that's the right answer. Okay, now let's go. Which child should the nurse assess first? Again, a toddler with stridor and retractions. B, a 5-year-old with wheezing after a runny nose. Now C, a 6-year-old with barking cough and low-grade fever. And D, a child with asthma asking for puff from their inhaler. And guys, the right answer is A, toddler with stridor and retraction. Now, let me explain it to you. Stridor is like a noisy sound you will hear when the upper airway is blocked. And also, this patient is experiencing retraction. Retraction is indicating that they are using accessory muscle to breathe. So that is indicating respiratory distress. So combine respiratory distress with stridor, that is the obstruction of the upper airway. Like we said, airway breathing and circulation, never place anything over airway, because if the airway is clogged or blocked, they are dead. So this child is at immediate airway compromised and need to be attended to immediately. The child needs urgent evaluation and intervention. Airway breathing and circulation, okay? Now let's go through the wrong choices. A 5-year-old with wheezing after a runny nose. So the wheezing they're experiencing may be due to a mild viral illness like bronchiolitis, but there is no sign of distress. They are not using accessory muscle to breathe. There is no sign of respiratory distress. They are not really unstable. That's why we didn't go for them. Who do you need to assess first? Who can die first? Whose condition can get worsened if you do not attend to them ASAP? That's your prioritization. Now let's go to C. C, a 6-year-old with barking cough and low-grade fever. Now, barking cough is like a mild sign of croup, and this can be treated at home. they have fever and backing cough. So croup is a common respiratory illness that affect the trachea, the larynx, and the bronchi, leading to inspiratory, stridor, and backing cough. And like I said, this can be managed at home. So it is not like immediately, like for something to be able to be managed at home, it's not life-threatening. It does not need immediate urgency or attention. There is no signs of acute respiratory distress like stridor, like we see in the first patient. So they are not, this last patient is not our priority. Okay. The last one, guys, a child with asthma asking for puff from their inhaler. This patient is stable. For them to be asking for puff, right? It may be a maintenance dose, like ibuprofen, which is like a maintenance dose, and it helps to open the airway and absorb the mucus in the airway, right? So the patient is stable, they are not in distress. It's important, but they are not in distress, okay? But safety is compromised in the first patient, and that's our right answer. Who should the nurse assess first on the labor unit? A client with ruptured membrane and green-tinged fluid. B, a client in early labor requesting an epidural. C, a client with mild contraction every 10 minutes. And D, a client in the latent phase eating ice chips. And guys, the answer is a client with ruptured membrane and green-tinged fluid. What is green-tinged fluid suggesting to you? Meconium. Meconium is the first stool or poo a newborn has to pass in the first 24 to 48 hours of their life. Like after giving birth to them, your baby have to poo within 24 to 48 hours. Because when I had my baby, the nurse made me understand that if your baby didn't poo or pee, you're not leaving the hospital. So that's meconium. And now so the green fluid you are seeing is suggesting that the baby already pooed in the womb, which is dangerous because the baby can aspirate on it or swallow it. That will cause respiratory distress for the baby. Also, that will cause infection for the mother. That is why that's our right answer. The risk with this number one patient is very much compared to the rest of the other patients or mother, right? This client that have green-tinged fluids, green-tinged fluid need to be attended to immediately. Now let's go to the wrong choice. A client in early labor requesting an epidural. Now they will not give you epidural if you are not up to between 4 centimeter to 6 centimeter. That's when you can get, if you are not dilated from 4 to 6 centimeter, that's when they'll consider giving you epidural. But they said in early labor, so which means this mother might be in the latent phase of labor, because remember there are stages of labor. The stages of labor is 4. The dilation stage, which is the first stage, the delivery of the baby, the delivery of the placenta, and the recovery stage. That's when you do the vital signs, resting, and everything, right? So this patient that is requesting epidural, they are in early labor, so they are not in any life-threatening situation. So why should we leave somebody that have tinged green fluids that cause respiratory distress for the baby, infection for the mother, and go attend to this second patient, right? So think about it. Okay, now let's go through the C. A client with mild contractions every 10 minutes. They are still like in the early phase of labor, so they are not your priority. And D, a client in latent phase eating ice chips. Yeah, in latent phase, maybe you can have dry mouth, and ice chips, like ice chips from the fridge, can help dehydration or dry mouth. So they are not experiencing any life-threatening issue compared to the first patient. Okay, which patient should they not see first? A 58-year-old with slurred speech and right-sided facial droop. B, a 24-year-old with a history of migraines asking for pain meds. C, a 40-year-old with dizziness and nausea after standing up quickly. And D, a 65-year-old with history of TIA who is now pain-free. Guys, the right answer is A 58-year-old with slurred speech and right-sided facial drooping. What is this suggesting to you? Stroke. If you have seen my video, I talked about it, stroke. And you use FAST to assess for stroke. F for facial drooping, assess their faces, the face drooping. A for tell them to lift their arm if the arms are drifting downward or one arm is drifting downward. S for slurred speech. You ask them to talk in their slurred speech. And T, once you notice all of this in your patient, time to call for the emergency line, time to call for the rescue team. So that's why you use FAST to assess for stroke in your patient. Now they have slow speech and right-sided facial drooping. That's suggesting stroke. So you need to intervene immediately. And stroke is the blockage of blood flow in the brain. If this persists for a long time, they will have a paralysis. It may lead to death, right? So it needs to be attended to immediately. They need immediate intervention to preserve the brain function. So these patients need to be attended to immediately. There is no wasting time in stroke, because if you do not attend to them immediately, the brain will dead because there's blockage of blood flow, oxygen to the brain. They'll be brain dead. That's dangerous and life-threatening. Okay? Now let's go. A 25-year-old with history of migraines asking for pain meds. Migraine is uncomfortable, but it's not life-threatening compared to someone having stroke. Right? You will not leave someone that has stroke and say, and you might say, okay, is it just very easy for me to just get the medication, give them migraine medication before attending to a patient that is having stroke? No, don't do that. Now, a 40-year-old with dizziness and nausea after standing up quickly. This is a sign of orthostatic hypotension, and you can tell them to sit back down. So it's not life-threatening. Changing position quickly, just like they said, standing up quickly can cause orthostatic hypotension, and when your patient experiences, just put them back to sitting or lying down. That's it. And a 60-year-old with history of TIA who is now pain-free. They have passed TIA. They are stable now. Look at what they say. Who is now pain-free? So why should they are not in any distress, any life-threatening situation? Why should we attend to them first? Okay, guys. Now let's go. Now, which patient should the nurse assess first on psychiatric units? A client pacing and stating, "I hear voices telling me to die." A client crying after a phone call with a family member. A client refusing to attend group therapy. And D, a client requesting a sleep aid. Guys, the first answer is A. A client pacing and stating, "I hear voices telling me to die." You know why? Command hallucination. If that voice they are hearing tell them to kill you, they will do it, because it's command hallucination. They will. So when your patient is experiencing this, stay far away. Distance. Calm, redirecting voice. Talk to them from distance. Because command hallucination, they will carry out what that voice is telling them. Okay? So command hallucination with suicidal ideation, kill yourself, kill the nurse, it's very life-threatening. It can put the patient himself at risk, the nurses, the other patients around. So that's why you have to attend to them first, right? Now, a client crying after a call with a family member. The patient is upset, but it's not safety concern, right? Now, a client refusing to attend group therapy. Refusal is common, but it's not urgent, right? And D, a client requesting a sleep aid. This, they are expecting their medications to sleep. This can wait compared to someone say, because if you do not treat that patient, attend to that patient saying, "I hear voices telling him to die," if that voice hear voices to go kill other patients, if that patient hear voices to go kill other patient, that patient will carry that out. So for the safety of the other patients, the nurses, the staff, the patients, him or herself, that's the right answer. Let's go. Which pregnant client should the nurse assess first? A 10-week pregnant woman with vaginal bleeding and cramping. B, a 30-week pregnant woman with heartburn and leg cramps. C, a 24-week pregnant woman with mild swelling in the feet. And D, a 12-week pregnant woman with nausea and vomiting. Now, guys, the right answer is A. Why? A 10-week pregnant woman with vaginal bleeding and cramping, that can indicate miscarriage. They are still very early on. That can suggest miscarriage. They might be going through miscarriage. So you need to attend to them first, right? They need urgent evaluation. Now look, 30-week pregnant woman with heartburn and leg cramps. Now, in third trimester, this is expected. Leg cramps, leg swelling, heartburn, all of that, right? Now, 24-week pregnant woman with mild swelling in the feet, common in pregnancy. It's not life-threatening. 12-week pregnant woman with nausea and vomiting, morning sickness, it's not life-threatening. Except the pregnant woman is having hyperemesis gravidarum, that is continuous nausea and vomiting. They can't keep anything down. That will cause electrolyte imbalance, because the baby in them needs oxygen, electrolyte. The mother has to be well for the baby to be well. That can be life-threatening. But they're just having regular morning sickness, nausea and vomiting. It's not life-threatening at this point, okay? Now let's go. Which client should the nurse see first? A client who received a first dose of penicillin and reports throat tightness. A client asking for their scheduled insulin. A client requesting help to the bathroom. and a client with mild nausea after chemotherapy. Guys, the right answer is there. A client who received the first dose of penicillin and reports throat tightness. First dose. You know, when you're taking a new medication, they put you on monitoring to see how the medication affects you. They are having allergic reaction to the penicillin. So they're having reports throat tightness, airway constriction, airway breathing and circulation, airway compromised. So why would you leave somebody with airway compromise and go attend to the rest of stable patients? Tell me why. Now, that's your answer. Now, a client asking their scheduled insulin. Insulin is important, but it can be given to them later after you've attended to the one that needs urgent and immediate emergency need. A patient with sign of airway compromise needs to be attended to first. Now, a client requesting help to the bathroom, this can wait, they are not urgent. And D, clients with mild nausea after chemotherapy. Nausea is expected, I've said it before, and it's managed, so it's not life-threatening. Now, let's go. Which client requires immediate isolation? A client with suspected tuberculosis and persistent cough. A client with C. diff requesting bedpan. A client with an indwelling catheter and cloudy urine. A client with stage 2 pressure injury. Guys, the right answer is A client with suspected tuberculosis and persistent cough. TB is airborne, so as they are coughing, infecting the whole place. So they need to be isolated immediately, instantly, right? To prevent other people inhaling that particle and getting infected, right? And that's why that's the right answer. Now, a client with C. diff requesting bedpan, that's his contact precautions, right? But it can wait after you isolate the patient that is coughing, that can spread it in the air and thousands of people can get it. That can, and then you isolate the C. diff. That can wait, right? Now C, a client with an indwelling catheter and cloudy urine. This may suggest infection because of cloudy urine, right? But look, it's not immediately life-threatening or take greater priority or emergent compared to somebody that spread infection that affects everybody, okay? And a client with stage 2 pressure ulcer. So pressure ulcer is not infectious, except maybe they take a culture and it's indicative that the pressure ulcer has been infected or it can infect you. Aside that, that's not priority, right? Now, which client should be seen first? A client with black tarry stool and dizziness. A client with iron deficiency anemia asking about iron-rich foods. A client with hemorrhage and bright red blood after wiping. A client with GERD who ran out of antacid. Guys, I know when you look at A and C, you might be dilly-dallying because you see bright red blood after wiping. And then A, black tarry stool. The right answer is A. Black tarry stool suggests what? Upper GI bleeding. That means the upper GI is bleeding because it's now black because it's coming from all the way from the upper GI. By the time it gets processed and get all the way out, it's already black tarry stool. So black tarry stool is suggesting upper GI bleeding. And now couple that they are dizzy. The dizziness may come from as a result of the bleeding, loss of blood, and they can be hypovolemic because they are bleeding internally, right? That's why that's your right answer, bleeding. Now let's look at B. A client with iron deficiency anemia asking about iron-rich food. This can wait. Education can always wait compared to someone that needs immediate or life-threatening issues, right? Or intervention. Iron-rich foods like dark leafy green veggies like spinach, like red meat, like poultry. You can educate them, but that education can wait. Now, a client with hemorrhoids and bright red blood after wiping. Hemorrhoids are uncomfortable but are not emergent, and the bright red blood you see is because maybe when they go to poo, the straining of the anus will cause bleeding. So, and the bright red blood is indicating that it's fresh. It's not like they've been bleeding from inside. It's fresh and it's in the lower rectum. That's why it's not life-threatening compared to upper GI bleeding. And the client with GERD who ran out of antacid. This is not life-threatening, and it's related to stomach, so it's not life-threatening. The last one, guys, the very last one, guys. I hope throughout this entire video it has not been boring. Please, if you've learned or enjoyed this video, don't forget to subscribe, don't forget to like, don't forget to comment your best part of this video. Thank you. Last one. Which client is the highest priority? A post-op client with temperature of 39 and blood pressure of 88/54. A post-op client asking for pain meds. A client with dressing soaked with serious fluids, and a client with stable vital signs and no complaints. Now, the right answer is A. A post-op client with temperature, they're experiencing fever, and look at their blood pressure is low. So guys, fever plus hypotension may indicate septic shock, which is a state of emergency. It needs to be addressed immediately, right? Right, guys? And another thing you need to know is if your patient's blood pressure, maybe they just had surgery or something, and after surgery, I've always mentioned that there are three things you need to monitor for: DVT, hemorrhage, and infection. Right? Now, when your patient's blood pressure is low and heart rate is high, it could be signs of shock, hypovolemic shock. But look, they are having infection plus low blood pressure, septic shock. Okay, now let's go through the wrong ones. A post-op client asking for pain meds. Yes, they just had surgery, they may feel pain, right? A client with dressing soaked with serious fluids. Serious fluids is not life-threatening, right? Except it's purulent fluids. That may suggest infection, but serious fluids is just not life-threatening. And a client with stable vital signs and no complaints. So you want to attend to patients that has stable vital signs, no complaint, and leave a patient that's at risk of septic shock. Don't do that. All right, guys, thank you. Have a wonderful one.